So I'm going to talk about pre-op planning. Pre-op planning means different things to different people. I'm going to go over some of the things that are important to me, and then some of the other speakers will go over some other stuff. So these are my disclosures. They're not relevant to this. So what changed since the last time I was here, COVID, and the silver lining about COVID for us was that we learned how to do same-day surgery. We did not do same-day surgery before COVID, so we had to learn, and we had to learn fast. If you're looking for a paper that gives you a pretty good roadmap, this by Antonia Chen and her group gives you a pretty detailed idea of how to get started. So we kind of gravitated to this paper in the beginning. But I'm going to tell you about a couple of things that we typically didn't pay attention to that we really paid attention to in same-day joints. Number one is anemia. We're hypersensitive about this. Anybody with a hemoglobin less than 11, we kind of shied away from that. It's amazing how many people have obstructive sleep apnea. If you ask them, they have the machine at home and they don't use it. So make sure they have it, they use it. If they were not compliant, we did not do them. Also, people with chronic opioid dependence, it's very hard to manage their pain post-op, so we shied away from them. Male patients with BPH, we would put them on Flomax preoperatively. Also, cognitive dysfunction. We did not have a hard cutoff in terms of age, but you gotta be careful with these people with early dementia because they're at risk of falls at home. And then people with allergies, true allergies to NSAIDs. If you can't use NSAIDs for pain management, it's hard to manage their pain without opioids, and these people will tend to stay in the hospital. And then the two other things is social support at home. It's funny because people say, I can't go home today because I don't have social support, but that's not gonna change tomorrow. So that's irrelevant. You gotta make them get social support. And also distance from the hospital. We operate on a lot of people that are like 2 or 3 hour drive away, so we make them stay in a hotel if they're gonna go home the same day. And then this is the disease-modifying agents. This is the table that we keep very handy in our office. This tells you when you have to stop them before surgery, and it's important. This is by ACAS and the Rheumatology Society. So this is kind of a Bible for us in the clinic. And then skin, Dr. Cooper already talked about this. If the skin is kind of tenuous, then my go-to is a Prevena. We have a stock of these in the hospital. But there's good evidence to suggest that the bikini incision is less morbid and with less wound healing complications. A big part of pre-op planning is templating. When you template, you can learn a lot about the patient. You learn the bone morphology. It may actually make you change the type of implants that you use. You template the size, the cup, and the stem, and then you template to optimize leg length and offset. This is what I go to the operating with. I know my size of the cup, my size of the stem, the tip of the shoulder to prosthesis distance, and my neck cut distance. I have that readily available and adjust accordingly in surgery. Be careful if the patient has a significant external rotation contracture because the morphology of that femur is going to look differently. The neck is going to be in more valgus. So in these patients, I typically template the contralateral, more normal appearing side, as you see in this case. I'm going to show you some good 3 examples of how things, when I template, may make me change what I typically do. This is a case with a guy with short varus necks. If I template my normal stem, I would be lengthening that patient almost 1 centimeter. So I look for a stem that has a proximal geometry more conducive to recreating his anatomy. So I did this on this patient. Then this is another patient that if you can see, he has type A bone. So I see this, my rep sees this, and he has the flexible reamers readily available. And if you're not looking at the x-rays carefully preoperatively, you won't notice this. And then in this patient, we went in and flexibly reamed and avoided distal potting the stem. And then this is a patient with type C bone. I typically don't cement a lot. I know Joe's going to talk about that, but I do cement sometimes. And if I see an old lady like this with previous fragility fractures of the rami and everything like this, so then I'll cement the stem and do a hybrid fixation. And then lastly is spinal pelvic dynamics. Again, I'm going to touch on this a little bit. This is a patient I did the right side. This x-ray looks pretty good. I was high-fiving myself. After surgery, 6 weeks later, I got called the patient dislocated anteriorly. If you look at the standing view of this patient, the patient anteverts significantly and posteriorly tilts a lot when he goes to a standing position. If you look at the supine view, he's 38-16 laying down, but when he stands, he's 48-40. So I overly anteverted this cup in this patient and led to an anterior dislocation. So, there's technologies to help you do this, but if you want, you can just do simple stuff. This is a standing view. This is a lateral standing and sitting. As you can see, sacral slope doesn't change much, less than 10 degrees. So by definition, this is a stiff pelvis. And when he sits, it actually rolls forward instead of rolls back. So this is a high-risk patient, even on an anterior approach, a young patient. So in this patient, I did a dual mobility mobile monoblock cup. There's other technologies. This technology that I use, you get a couple x-rays preoperatively, and then it tells you where the cup is standing, sitting, and laying down. And then with a angle that you can draw in surgery based on the AP pelvis, it can tell you and extrapolate where that cup is going to be standing, laying down, and sitting. So again, there's multiple technologies that can help you look at this specific issue. But you can do simple stuff just like just getting your own x-rays and drawing your own angles in the office. So in conclusion, from a medical standpoint, you got to optimize and modify what's modifiable. I mean, I'm still amazed that a lot of people don't template. I think templating is very important. I template my fellow templates and my rep templates, and you got to have a plan to execute. And I think you have to understand the spinopelvic issues and adapt accordingly. Thank you so much.